Good morning, everyone. We'll get started. First case, peds. We have a right-hand dominant 15-year-old male. He was wrestling for his high school team. He sustained his left ring finger P1 fracture. It's a long spiral. I buddy taped the patient. There's no rotational deformity.
Is there a way to get the video running?
Oh, right. There's a way. It's to get the video running. This was that case.
How do you know there's no rotational problem?
I saw him.
I know, but what did you do physically on exam?
Sure. So I did tenodesis, and then I just also asked the patient to flex as much as he could. He was a little limited, but they all pointed towards the scaphoid tubercle.
Great.
Next patient is a 40-year-old female, right-hand dominant. This was MVC. It was a low-speed collision. She said she had this left humeral shaft fracture. She was placed into a coaptation splint. She'll follow up in the office. Army into a bracing. Next patient is a right-hand dominant 68-year-old female. She also had a ground level fall. She had this shoulder greater tuberosity fracture. She was placed in a sling. She's made non-weight bearing. She was encouraged not to perform active abduction or passive adduction. Next is a 51-year-old female, status post-ground fall. She had this left shoulder dislocation. She was close reduced. We saw this large Hill Sachs deformity after reduction. Next is a 21-year-old male, right-hand dominant. He sustained a ground level fall at home. He had this right shoulder rear tuberosity fracture, as well as shoulder dislocation, so complex dislocation. He was close reduced, or the greater tuberosity piece is still displaced, and he's going to be in the office this morning for discussion of surgical plan of operative fixation. Next is a 50-year-old female. She fell while ice skating. She's right-hand dominant. She sustained this right distal radius fracture. She was close reduced, placed into a sugar tongue splint.
Jomar, what are you going to address with that shoulder fracture dislocation surgically?
The greater tuberosity displacement.
Are you going to do anything else?
I would, but I don't know that I know exactly what it is. Perhaps the rotator cuff would try to assess the competency of that. We want to assess if this was a primary dislocation. I guess we'd assess his ligamentous status, see if he's very lax. I didn't get that sense as I was doing a reduction.
Do you think he has a labral tear?
He may. So I think we should assess that as well.
How does the tuberosity get in that position? It seems like it's inferior to where it needs to be.
Yeah, so in fact, I thought of that, and I figured the rotator cuff may be incompetent at this point. If tuberosity was allowed to go inferior as opposed to being pulled up by the cuff. By the
would it be worthwhile in this case to get any additional imaging?
Yeah, I think perhaps a CT scan would have been a good call in this case primarily.
So do you think a CT scan is a good answer?
Or an MRI?
I mean, what do you
if our question is for soft tissue problem, right. Certainly the MRI.
So Jomar, do you think the rotator cuff is torn, or the energy went through the bone and caused the fracture instead? Like, do you think that both a tear and a fracture happens at the same time?
I think that's probably uncommon, but the position of the greater tuberosity is curious. So I think that there's probably both a fracture and a tear.
I think the position of the greater tuberosity it's almost analogous to a large Hill Sachs lesion. Gotcha. And that's why it's depressed.
Next, we have a right hand, thank you guys. Next, we have a right hand dominant 61-year-old male. Stats was ground fall with this right distal radius fracture, carpal subluxation. He was closed reduced, placed into a sugar tongue splint. Next, we have a 50-year-old male. He had a fight. I presented him last week. I placed him into a sugar tongue splint at the time. He came without the splint this week, and I placed him into a short arm cast. First ulnar shaft and his fourth and fifth metacarpal base fractures. This gentleman was also in a fight, 19-year-old right hand dominant with his right fifth metacarpal base fracture. He lost the fight. I could see he was placed into AP slabs. Next is a 60-year-old male, right hand dominant, sepsis fall. He said he fell onto his hand. He has this right fifth metacarpal neck fracture. Of note, he's certainly broken this bone and others in the hand on several occasions in the past. He's pretty functional even with the angulation, the baseline angulation of the metacarpal neck. So I did buddy tape for that gentleman. Next is a right hand dominant 28-year-old male. He was in a fight with the wall. He had a right fifth metacarpal neck fracture, significantly angulated. So I did a closed reduction and placed in AP slabs. And then finally, we have a 32-year-old female. She fell 4 stairs. His right trimal ankle fracture, as well as a second through fourth metatarsal base fractures. Just placed into a posterior splint. I got a CT scan to further characterize those fractures in the foot. This patient will be seen in follow-up today, I believe, and she will be scheduled for surgery. Thank you, guys.
Hey, Jomar, that radial tuberosity fracture that you showed the older person, not the dislocation. You told him you were kind of adamant about the person not actively abducting, and how are you going to manage that patient? Like, what, they come to your office in a week. What are you going to tell them?
Sure. So I guess we'll get new films. We'll see the position of the tuberosity for her.
It hasn't changed.
It hasn't changed, so I'll let her know.
It's not changed.
Pardon me?
And so it hasn't changed, so now what?
Yeah, and I'll let her know that that's good news for her. This portends well for non-operative management. And we'll probably start liberalizing her motion after about 2 weeks. If it hasn't, it continues to be in a stable position, first with just, gentle passive range of motion with pendulums. And then we can start doing active range of motion at about I would say the 3 or 4 week mark.
I don't think you want to scare that person too much about moving their shoulder. The likelihood of the tuberosity displacing at a later date is relatively low. And your bigger problem with that, the biggest problem with that patient is going to be a frozen shoulder when all is said and done. You'll be fighting, a lack of motion. So, I would get pendulum started really early. As soon as they come back, there's no harm in doing pendulum exercises, and then they can do active assisted motion. I get them doing like a wall climb exercise as soon as they're comfortable enough to do it. They can't do it. It's self-limiting early on, but later on, at a week out when they come to your office, you got to kind of take an opposite opinion and get them moving, because frozen shoulder can be a real pain in the ass to get better.
Sure, I'll keep that one in mind. Thank you.
First patient's a 29-year-old male, status was fall with a left proximal radial shaft fracture. He was made non-weight bearing, placed into a sugar tongue splint. The plan for this guy is to follow up in Texas. That's where he's from. He has an upper extremity specialist from when he fractured his distal radius 2 years ago. So we'll follow up over there for surgical management. Next is a 67-year-old female, status post-fall with a left distal both bone forearm fracture. She was closed reduced, placed in sugar tongue splint. She'll follow up in the office this week. Next is a 9-year-old female, status post-fall with a left both bone forearm fracture. She was closed reduced and placed into a sugar tongue splint. Next is a 9-year-old
John,
male.
I'm sorry, John, just to go back a second, are you going to treat the both bone forearm fracture non-operatively if the reduction looks okay, or are you going to move to an operative fixation?
I think the reduction of the radius is pretty good. You know, there's a little bit of an articular step off, you know, right here. So that's definitely something to keep an eye on. The ulna is a little bit angulated, which is kind of my major concern about treating this non-operatively. So I think we should get some x-rays and, you know, see how she's doing. And I think it could go either way.
Yeah, I worry about this one a little bit. You know, there was a paper published on, you know, distal radius fractures, and then if there was an ulnar neck fracture, and the outcome was saying if you fix the distal radius, a lot of times you didn't need to fix the ulna. But this ulna is very displaced, and I worry about your DRUJ here. So it's not as much the radial alignment, but this is one I think I'd push more for operative fixation on.
Thanks. The next one is a 9-year-old male, status post fall from a hoverboard, right both bone forearm fracture, close reduced, sugar tongue splint. Next is a 60-year-old female, status post fall, or status post MVC rather, with the right small finger P1 base fracture. She was blocked and close reduced, placed into an AP slab splint. Next is a 54-year-old status post fall down about 20 stairs with a right acromion fracture, a right lateral epicondyle fracture, as well as like a small chip off the forearm. He's going to be managed non-operatively in sling and a posterior splint for the elbow. Next is an 85-year-old female, status post fall, with a pathologic right femoral shaft fracture. She has a history of osteoporosis with bisphosphonate use. She has, you can clearly see here, some cortical beaking fracture through that. On the contralateral side, we obtained x-rays which showed cortical beaking and as well as like a faint dreaded black line. So initially, we took her to the OR for right femur intramedullary. We have plans to take her back electively for the left side. Next is a 79-year-old female, history of Esrd and hemodialysis. She's bedbound for several months, maybe up to a year per the family. She has a left hip intertrochanteric fracture. She underwent left hip intramedullary nail. On postoperative imaging, there was concern for a longitudinal fracture line here, just distal to the implant. So we obtained a CT scan, which kind of confirmed our suspicion. So she's bedbound. So we're going to make her non-weight bearing for now, or sorry, a toe touch, technically weight bearing for now, and plan to manage her non-operatively for this.
Morning. First patient's a 54-year-old male who fell on the sidewalk and has a right proximal humerus fracture. He was placed into a sling. There's a 28-year-old male who was in a motor vehicle collision and has this right distal radius fracture. The pattern on the x-rays was concerning. So after being placed into a splint, he was taken for a CT. That shows dorsal Barden pattern. Also the small fleck off the triquetrum. He's going to follow up this week for a surgical planning. is a
So
28-year-old.
what would your surgical plan be?
So I would start dorsal, and I would try to book open the fracture and see it. You know, he probably avulsed the ligaments volarly, and that could block the reduction. So I would want to book open the fracture if I could, and make sure that there's nothing blocking us intra-articularly, and then plan to put a buttress plate there. If we were not able to get it reduced properly, then we might have to go volar to clear things out.
I think you're thinking about something else. Pretty rare to have true volar wrist ligament injury here. I definitely think this needs dorsal fixation. So, but you'd probably start dorsal and stay dorsal. The lunate facet does not look involved here. I had one of these where the lunate facet was involved and non-displaced escape after I put a dorsal plate on. So you have to be very concerned about that. But this CAT scan looks pretty clean volarly. And the volar wrist ligaments are not going to be injured unless you have a sort of perilunate type or lunate dislocation type Mayfield arc injury. That's not what's going on here. So this definitely needs a dorsal plate.
So how do you think the lunate gets all the way up dorsally in relation to the volar portion of the radius? There's no fragment. Okay, a lot of times we'll see a little fleck of bone or big volar piece. Here, there's no piece, but the lunate is not anywhere near the volar portion of the radius. You think that ligament just stretched a centimeter?
Well, it looks like the lunate may have shortened. I mean, it could be stretched. I doubt there's the entire volar ligament complex is off. I guess it could be, but I don't think it's interposed.
I think the only way to know if it's interposed is to reduce it. The chances are that you'll be able to reduce it, but don't be surprised if it doesn't go all the way down. And I don't know how that lunate can get there without some type of an injury. This is a pretty bad injury, and the lunate is pretty dorsal. So they recognized it, which is good. They got a better view of the anatomy, which is great. They made the right decision to go dorsally. I think to say that there's no volar injury, I think it's to keep that in the back of your mind, because you could run into a situation where that's a problem.
Next patient's a 28-year-old male who was having a psychotic breakdown and punched a window. Has this right small finger metacarpal neck fracture. He was buddy taped. This is an 85-year-old female who fell at assisted living and sustained a right hip periprosthetic rear choke fracture. She had a CT to better assess the fracture. It appeared well fixed distally with some stress shielding. She was made protected weight bearing with a walker. This is a 29-year-old male who had a motor vehicle collision 10 days prior to presentation. He was seen at an outside hospital where they gave him an Esrd and told him to find an orthopedist to follow up with. He had been walking on this and it remained non-displaced. So I put him in a short leg cast. This is a 49-year-old male who sustained a fall a week prior to presentation while extremely intoxicated, presented again drunk, and was found to have this bimal-equivalent fracture. We were considering taking him to the OR, and then he developed some significant cardiac abnormalities. And due to that and his severe alcohol use, we decided to treat him non-operatively in a short leg cast instead. There's a 97-year-old female who twisted her ankle a couple of days prior to presentation and showed up with this right ankle trimalleolar fracture. She has extremely severe cellulitis in her foot and ankle with multiple areas of blistering, and she is not a good operative candidate. We decided to treat her in a removable posterior splint so that her wounds can still be addressed, and we'll continue to follow her to make sure that she does not displace further.
morning. The first patient is a 40-year-old male, status was fall, who was transferred from on-site hospital with right tibial shaft fracture with extension to the ankle. Patient was taken to the OR for right tibia IM nail and ankle close reduction and internal fixation. Next patient is 91-year-old female, status was fall with right open distal humerus fracture. The patient was taken to the OR for right elbow irrigation and debridement and distal humerus open reduction and internal fixation. Next patient is 87-year-old female, status was fall with right periprosthetic humerus fracture. The patient was taken to the OR for right humerus open reduction and internal fixation. Next patient is
any thought of using a strut on that proximal humerus fracture? That one.
Yeah, so that was initial thought to put the struts, but when we opened that, we find out that the bone quality was not super bad, and we put locking plate. So we decided not to use struts.
Andre, can you treat that without surgery?
So that's a Caulfield B. So theoretically, if there is a fracture distal to the prosthesis, we can start treating non-operatively. And if it's good results, we can observe for 6 weeks. But in this type, it's a fracture style around the tip of the prosthesis and extending distally. So, and there is significant displacement more than 2 millimeters. So in this type of fracture, surgical treatment is recommended. And there are 2 options, ORIF, and most people using a plate with the struts or locking plate, like we use the locking plate. And we also evaluated the stability of the prosthesis. If there is instability, it also can be the option to exchange the prosthesis with the long stem. But the prosthesis was stable in this case, so we decided to do ORIF.
What literature are you referencing about the fact that this can't be treated closed? What was the article that you were?
Yeah, so there is article from, I believe, 2012. There's a review of the periprosthetic humerus fracture. And they classified, Caulfield classified this like 3 types. Type A, it's a fracture proximally to the tip of the prosthesis. And in this case, it's mostly unstable fracture and it requires prosthesis replacement or exchange. Type B is the fracture starting at the tip of the implant and extending distally. And because the fracture starts at the level of the prosthesis, the healing is not very good, especially if displacement is more than 2 millimeters. And the authors recommend surgical treatment of these types. And type 3 is the fracture distally to the tip of the implant. And for this type, they recommend non-surgical treatment. If it fails, then surgical treatment.
So when you say not healing, like 80% won't heal of these?
I don't remember the number, but it was like 40%, I believe.
An healthy 87-year-old?
So this patient was not super healthy. She got like multiple comorbidities, but she was cleared by cardiology for.
And what was her shoulder motion before she broke it?
She used this hand for activity of daily living. So I assume it was not very bad.
Well, an 87-year-old activity daily living just needs 60 or 70 degrees of motion on one side, and she could do fine. So I don't know.
She also used walkers, so she needs these hands for ambulation as well. So that process.
Even if it didn't heal, and she had a fibrous union, she's probably going to be okay. All right. I think it's probably a good thing for everybody to review because it's not a common problem. Yeah. Thank you.
Thank you. And next patient is 50-year-old female status post MBC who came as a trauma with right open subtalar dislocations with associated talus and navicular fracture and 5th metatarsal base fracture. We also find out that the patient has right tibial plateau fracture on the same side, and on the other side, she has bilateral ankle fracture. So the patient was taken to the OR for right tibial plateau ORIF, and she underwent left ankle open reduction and internal fixation, as well as right foot IND open reduction of the subtalar dislocation. And because the dislocation was unstable and the patient has tendency to subluxate in the talonavicular joints, next day she came back for another IND and we put the X-fix. Thank you so much. That's all cases from Robert Wood Johnson.
Good morning. All right, first patient's a 29-year-old female presenting after a ground level fall. The left occult radial head fracture. Patient was neurovascularly intact, no blocked motion. Was mobilized in a sling with early range of motion. Next patient's a 77-year-old male presenting after a ground level fall with a right distal radius fracture. Patient was neurovascularly intact, closed reduced and placed into a sugar tongue splint. Next patient's a 55-year-old male who presented about 2 days after falling from a bike with the left distal radius fracture. Patient was neurovascularly intact, closed reduced, and placed in a sugar tongue splint.
What kind of anesthesia did you use?
I used a hematoma block. I mean, it wasn't a great hematoma block, so I did have to give him some, additional pain medication, but it was enough to do a close reduction.
Good job.
And would you fix this fracture if this was your patient?
I think I would watch it. I think the way the reduction is right now, it's definitely acceptable. And I think if it maintains this reduction, then, he can have a good outcome. I definitely would, consider fixing it if it loses reduction.
How would you define an unstable fracture? What would some of the criteria be?
So, I mean, we can look at like LaFontaine's criteria. So, if there's at least 3 of the criteria, so, 20 degrees of dorsal angulation, dorsal comminution, if it's intra-articular, if there's an associated ulnar fracture, if they're over the age of 60, then we would, consider that to be an unstable fracture and unlikely to maintain reduction. Next patient's a 64-year-old male presenting after a ground level fall with a left femoral neck fracture. Patient was optimized and taken to the operating room for a left hip hemiarthroplasty.
Do you have a lesion in that proximal femur?
No, there was no lesion. He didn't have any antecedent pain or anything like that. He was 64, but physiologically he was much older, had like many medical comorbidities, and he was ambulatory with a walker already at this stage. So. Next patient's a 77-year-old female presenting after a ground level fall with a right distal femur fracture. CTs were obtained to further characterize the fracture pattern. Patient was taken, medically optimized and taken to the operating room for right distal femur open reduction, internal fixation. Next patient's a 29-year-old female presenting after fall down a couple of steps, the right ankle bimal-equivalent ankle fracture. It was stress positive. Patient was closed reduced and placed in a short AO splint, and patient was from out of state, so patient will follow up back home for surgical planning.
And just go back to that distal femur and the fixation that you chose there. Tell me a little bit about that plate, and are those locking screws in the plate?
Yeah, so this is just like an anti-glide buttress plate, since it was just a lateral condyle fracture, and the 2 distal plates are locking screws. We had initially planned to put lag screws to provide additional fixation, We attempted that, but we couldn't get good fixation. So we had, changed our plan and opted to go for locking screws distally.
Is this construct strong enough to walk on?
No. So, I mean, normally we would let these patients be toe touch weight bearing, but this patient's kind of unreliable. So we made her non-weight bearing for the time being, but we're going to allow her to have some range of motion just to prevent stiffness in the knee.
So how did you obtain your reduction? So you're maintaining your reduction with this anti-glide plate. How did you get the fracture anatomic?
So we open reduced it, and then it actually reduced pretty easily. We kind of provided like a valgus stress and some axial traction, and we're able to just manually reduce the piece. And we temporarily held it in with some K wires, and once we put the plate on, everything held pretty well.
So did you compress the fracture at all, or did you just manually reduce the fracture and then put the plate on?
I guess we just manually reduced it and put the plate on. I mean, we tried to, we compressed it with the clamp, I guess, but it's not, great compression. We tried to compress it with the lag screws at the end, but again, we couldn't get good, good fixation with the lag screws, which is why we ended up opting for the locking screws.
Yeah, there's different options of doing it. So a clamp's a good way to get compression, right? Sometimes you put in screws, compression screws, and switch them out to locking screws. I guess I was just interested to see how you got it anatomically reduced. So it sounds like more of a clamp and then just put your plate on.
Yeah.
Did you initially put the screws in the non-locking holes and then abort and put the screws in the locking holes?
We did one of the screws in the non-locking holes, and once we realized we weren't getting good fixation, we just opted to do the rest of the. We switched over to the locking hole, and then for the other screw, we just went directly to the locking hole. Thank you.
Good morning. This is a 36-year-old female who fell off of her first couple steps outside of her home and sustained this left mid-shaft humeral shaft fracture. She was neurovascularly intact on arrival, and she was placed into a coaptation splint with a cuff and collar. She remained neurovascularly intact, and she will follow up for functional bracing likely. That's it from St. Peter's.
Anybody else?